Welcome back, everyone. Hope you've had a bit of a break. I'm going to introduce the next session. We've been delighted to get more attention for epilepsy within the NHS plan and the transformation programme. And some of you will have some awareness of this, and others it may be new to you. We're going to be joined now by Simon Kenny, who's National Clinical Director for Children and Young People, and Jaffer Ismail, who is the Integration Policy Manager for Children and Young People. And they're going to lead the session. In the background, backstage, we have Richard Owen as well with us, who's the lead for the CYP Transformation Programme. So he'll be available to join in should the need arise. So I'm going to hand over to Simon and Jaffer now to tell us what's going on. Thank you.
Thanks, Colin. So welcome, everybody. I'm Simon Kenny and really pleased to be here this afternoon representing the Children and Young People Transformations Programme. And I think would be really keen to sort of get feedback on what we talk about today and what your perception's been of how we've been working over the course of the last year or so since we've done the programme. And it's been a great pleasure for me to co-chair the Epilepsy Transformation Programme for Children and Young People. A little bit about me clinically, I'm actually a paediatric surgeon at Alder Hey, but my practice does involve looking after plenty of children with complex needs and things like that, so it's been very helpful. Just hold on a sec, I'll just, someone talking loudly in the background, I'll just ask them to possibly move. Sorry about that. So for those of you who don't know, the NHS has been in the transformation programme is about 3 years old, and it started as part of the long-term plan. And it was really the first time that children and young people have featured in that. And at the same time as the Children and Young People's Transformation Programme came to be, there's been quite some fundamental changes in NHS England. So the funding has been transferred largely to regions, and the national roles have been relatively reduced in terms of providing standards and guidance. But we've been very lucky to have children and young people recognised across the board. And it's quite a wide programme, but the processes which we are clearly involved with is the integration programme. So moving from regions into integrated care systems. And that for children and young people is a wider issue than potentially in other areas, in that we need to integrate care into education as well as social care. And then also within it is improving quality of care, and this is where epilepsy comes in. So the long-term conditions that were particularly highlighted in the long-term plan were asthma, which is obviously the most common condition, diabetes, obesity, and epilepsy. And so there's been, to a certain extent, some winners and losers in terms of those long-term conditions, and epilepsy is definitely a winner. I think that what we hope to do is get the learning from all the long-term conditions we're dealing with and roll them out to children with other conditions, because we're aware that we're not capturing all children through this process. But it's good to see that epilepsy is there. And Colin will have shown you will have seen in the Epilepsy12 data that Colin's presented the scale of the challenge that we've got and that we need to work with. And it's inclusive. So within our programme, and you can see on the background that we've got that the logo we've got is being developed by the Children and Young People. We have children and young people at board level from NHS England. I'm very keen that their voice is heard right throughout the programme. And I think the work we've done in the last year has really highlighted the fact that if you listen to children's experience, then they highlight the problem, and young people's, they highlight the problems, and they can lead us in how we need to deliver care. So we have to be very aware of that, and I think that the programme really reflects that. So as part of it, we've taken the National Epilepsy12 audit, which is really our best source of data for the quality of care in epilepsy, and worked with that data to essentially bring out 4 key strands, and that was working with experts and with children and young people and charities to determine what were if we were going to do something, what would be the 4 things we do. Conscious that it is just 4 things, and the Epilepsy12 audit will already have highlighted the fact there's loads of other things that you can do. But essentially, if we don't focus on those things, then we won't get any effective change. But I can already see within the programme that we're starting to improve quality of care around other things and provide a rallying point for epilepsy services nationally, which means that there's a point at which we can influence policy and strategy. So those 4 areas are probably not unexpected to you. It's the mental health screening and access to psychosocial support, and we'll come on to all these in a second. The access to surgery, that critical period where right across the NHS, I think we let children down, and that transition from living at home with your parents into adult epilepsy services, and then addressing variation in care, which is a sort of wider agenda. Sorry about the size of these graphs, and normally I hate graphs with large y-axis with nothing on it and then a big x-axis, but it actually just emphasizes what the issue is. So in terms of mental health screening and mental health provision, top left is mental health screening, and you can see that we are at a fairly low bar in terms of when we routinely assess children in epilepsy clinics, making that formal screening around mental health. And I think this has been educational for me as a surgeon, and we're actually bringing this into our clinics surgically for children with long-term conditions as well. So I think there is some learning that we can get. And then in terms of mental health provision facilitation, again, it's a low bar. So you can see that we've got a clear agenda to address there. And I think it's also really important to identify the fact that we don't want to get true separation of physical and mental health. I think they are joined. As clinicians, we all have responsibilities in both directions. And so any model we come out with should it not just default to transferring care to another profession. It's about how we care and identify problems and then refer the relative children and young people on when required. And so specialist surgery and specialist neurological care, again, you can see that y-axis was a bit of a void. And so that's the number of children needing epilepsy surgery on the left, and the number of children requiring meeting criteria for specialist referral who don't get that. And the reasons behind this are multifactorial. It's not simple, and it probably will vary between different regions and networks. But essentially, that's, again, one of our focuses. Jaffer, yep. And then transition, a similar but slightly better picture. So we would probably further on this journey than in the 2 examples that I've used before, but still there's a void of practice that we need to sort of ensure that it's consistent for all children with epilepsy. And then finally, the variation in care provided to children with epilepsy. And I think the evidence-based one really is the provision of epilepsy specialist nurses, because there's a clear evidence base that you get a better standard of care, you get more consistent treatment if children and young people have access to those specialist nurses. And they're very often the glue that holds services together. And you can see that there are, it's not a completely bad picture, but there is a gap there which we need to address. So Jaffer, I've set the ground. I've created all the problems, and you're going to now tell us what the solutions are.
Thank you very much, Simon. So I think Simon there has really clearly explained the evidence base for our 4 areas of focus in the programme. And so in order to take forward actions around these areas, we've established a national epilepsy oversight group, which consists of key stakeholders and organisations working within the children and young people's epilepsy space. And as Simon mentioned at the very start, a golden thread throughout our policy development across the whole transformation programme is in ensuring the voice of children and young people are heard. And our work in epilepsy is no different. Our oversight group is jointly chaired between NHS England, but also Young Epilepsy, to represent the voice of children and young people, ensuring that it's embedded within our programme of work. We've also funded regional clinical leads within each of our 7 NHS England regions in order to provide that local clinical leadership and to interface with integrated care systems. And our regional clinical leads are really essential in delivering our programme of work across those 4 areas and are embedded within their relevant regional governance structures. I think we're really fortunate to have an excellent and diverse group of clinical leads with different professional backgrounds, and I'm sure you may recognise some of the names there. I think it's important to note that our leads are still relatively new in post, with some just starting over the past few weeks. But I think as our programme matures, I'm sure that many of you will come across your relevant regional leads, and we anticipate that they will work really closely with Open UK networks, which we see as being a vital asset in the delivery of the improvement work. We've also worked really closely with the team at Epilepsy12. We see data as a real key enabler for the programme and for our clinical leads as well. And so we've worked with Epilepsy12 to identify key metrics based on our 4 areas of focus, and really importantly, to aggregate that data at NHS England and ICS level footprints. And that's really important because previously the data wasn't cut according to NHS England geographies, whereas by having this now made available, we can identify variation and gaps at that system level, which is where commissioning and governance will increasingly sit at. We recognise there are some limitations with the Epilepsy12 data due to data completeness due to COVID, for example, and some of the time taken to complete aspects of that clinical audit. But I know that Colin and the team at Epilepsy12 are working really hard to reduce that the workload associated with the clinical domain of the audit. But nevertheless, there's some really valuable insights with the current cohort of data, and the regional data packs that have been produced really do provide a valuable starting point to understand that variation. We've also formed some national working groups in each of those 4 areas of focus. The aim and objectives behind these working groups are there to inform a series of suggested standards and recommendations for our regional clinical leads and for systems, as well as signposting or indeed developing, if required, supporting resources. And these working groups were launched in collaboration with Open UK to ensure that we had that breadth of professionals and expertise on the group, as well as in collaboration with Young Epilepsy, again, to ensure that the voice of children and young people are represented throughout those working groups as well. The working groups are very much still live and in progress, and have met several times. I won't be able to share any sort of specific recommendations coming out just yet. However, just to give an indication of some of the emerging themes, you can see some examples on the slide there. So, for example, within mental health, we're looking around screening tools, models of integrated mental health care. In the tertiary care and CAS working group, we're looking around the importance of mapping clear referral pathways, waiting times for tertiary neurology input, ketogenic dietary therapy, VNS insertion discussions, for example. In the transition care working group, we're looking at developing a framework which consists of essential and desirable components for a good transition service, with a specific focus also on patients with learning disabilities and autism, as we know that's a really important cohort of patients to ensure that transition is right for. And finally, in the variation in care working group, a key aspect has been around epilepsy specialist nurses, which really is a key thread throughout all 4 of these working groups, really, but also looking at various other aspects such as SUDEP, which I know there's a presentation afterwards, which will help to inform some of our thinking on that as well. Finally, just wanted to take the opportunity just to flag that we're also currently working with the Healthcare Inequalities Improvement Programme to develop a children, young people specific version of Core 20+5. So just for background, for those of you who may not be aware, Core 20+5 is NHS England's approach towards supporting the reduction of health inequalities. And essentially it identifies a target population cohort, which is represented through the Core 20, which is the most deprived 20% of the population. It then identifies plus groups as well, which are population groups who experience poorer than average healthcare access, experience and or outcomes. So for example, that would be children, young people with learning disabilities and autism, for example, or looked after children. And then the 5 represents 5 key clinical areas for health inequalities. And we intend that epilepsy will be one of those 5 clinical areas. We know from the Epilepsy12 data, for example, that there's a clear social gradient associated with epilepsy diagnosis. And we also know from the learning disabilities mortality review of sometimes poorer outcomes in children and young people with epilepsy and learning disabilities and autism. And we hope to be able to share more details on that soon. So in conclusion, the early focus of our programme very much has been on developing the infrastructure. As I mentioned, we've established that national oversight group to bring together key stakeholders and to coordinate action. We've funded regional clinical leads to deliver the programme, and they'll be informed by the data, as well as the voice of children and young people with epilepsy, and outputs from those working groups. And I think as the improvement infrastructure beds in and the programme continues to develop, we hope that we'll be able to make some meaningful change and progress across our 4 areas of focus. So I'll pause there, and I don't know, Simon, if you have any closing remarks.
Yeah, thanks, Jaffer. That was hopefully covered it for people. I suppose the bit for me I'm interested in is whether this is news to people and whether they are aware of this programme. If you are, then I think the regional leads will be coming around to each hospital. I think what we're doing in terms of data is working with the data packs, and the regional leads will be visiting you in a supportive and friendly way, but just to start to get that depth of discussion about where we're seeing the variation in care and why it's happening. And from that, we should be able to see significant improvements. I suppose one of my backgrounds prior to doing the job as National Clinical Director, which I'm still involved with, is the Getting It Right First Time programme. And for those of you who don't know that, that was a programme of essentially where you show data to providers and start a discussion about where we see variation in care. And this is very similar vein, I think, in terms of the conversations which people will be having. And what the evidence shows from things like Getting It Right First Time is that having that external support and input will help you in having discussions with providers and within regions in terms of getting the resource where you need it. Not all everything needs resource. Some of it does, and we're here to help you when we can.
Thank you so much, Simon. And Simon, did Richard Owen want to come in at this stage?
No, I'm okay, Richard. I think it'd be good to open up for any questions.
Wonderful, wonderful. We haven't got any questions on the Q&A board. I think what it might be interesting to think about is, let's say that there is an epilepsy team conscious of NICE guidance, perhaps conscious of a gap between what they're able to deliver and what NICE guidance mandates. Within this new system, how would you see them being approached to make change? Who do you see that they will in the future be approaching to make change within the transformation process?
Shall I start, and then Jaffer, Richard, and Colin may have some input as well, actually. So I think first part is identifying where you are in the system, and data is interesting because when you look at those graphs, I suspect that you won't necessarily see the same problems in different trusts. Everyone will have slightly different problems. And obviously there's going to be a difference between tertiary and secondary epilepsy services as well in terms of provision. But essentially, by showing this data and by setting national standards about what we expect, that should provide a significant amount of ammunition for clinicians and clinical leaders, especially with regional leads, to approach providers and start that discussion. And so it is always interesting, isn't it, when you look at that, well, how come some trusts have managed to find the money to support epilepsy nurse specialists and others haven't? But there's something a little bit about lighting the fire underneath that discussion and saying, okay, well, why is it, are you like that? So I don't think necessarily the answer is always going to be suddenly dropping money from heaven. It's going to be about just having those discussions, which can be quite difficult. And we, as a national team, we're there to back that up so that if those discussions get a bit stuck, we can weigh in as well. And there's also, as part of the transformation programme, we've also appointed a regional generic CYP transformation team, so with clinicians and managers at regional level, so that to try and unblock any blocks if they are something that's coming from a regional level. And then within specialised commissioning, we work really closely with specialised commissioning. And so at the sort of, within the surgery and the more tertiary elements, we're there to support as well. So I think it's about And I think you can already see it talking to the regional leads, this shared community of practice about people saying, I've got these problems, and suddenly realizing that someone's actually sorted it in another region. And you can see that already happening. And I think it's more powerful. Before I started doing things like GIRFT, I was a little bit skeptical about this, but actually I can see, having done some other programs that are a couple more years down the line, you can see that transformation occurring, and you can see the benefits to children and young people coming through, and that's what we want to do, isn't it?
Yeah, and I think to add to what Simon, hopefully what's coming through, you know, we're quite early on, I think, with this program of work, but hopefully what's coming through the presentation from Simon and Jaffer is we've been really focused on getting the building blocks right at the start, and that's included not sort of ignoring what's gone before, which is really important. So making sure we've got, you know, the clinical rigor, we're building on the evidence, and then, again, thanks so much to Colin for all the work he's done to sort of NHS Englandify some of that data and evidence, so it works for the, you know, the people that Simon, Jaffer, and I are talking to day to day. And then focus down on what are the areas that we need to sort of set some direction on, and what are the sort of interventions, how do they start falling out of that. And I think that's the journey, the process, where we are in a journey is looking at that. Now we can start looking a bit more detail at interventions and how we spread those. I think one of the things we've learned from the programme is, obviously NHS England works in a national, regional, local sort of delivery model. For children's services, that can look quite different depending on the long-term condition, or depending on the setting, or depending on what it is we're trying to influence. So I think it'd be really important how the regional leads work with providers, with patients, etc., in their patch, just to look at where are the right places in the system and the structures to make sure we can influence the things we need to influence, make sure those interventions are in the right place. I don't think we can decide that, and we shouldn't decide that all centrally. But I think there is a role for the regional leads to work with their, you know, stakeholders locally to do that. I'm sure they all are really keen to do that as well.
Fantastic. Thank you. So, so for all of you there in epilepsy teams, then you can approach your regional epilepsy team. There's the national oversight group to back them up. There's support for the specialist services, and so that, you know, Simon spoke about ammunition, and we've been asking for that ammunition and leverage, you know, at this conference for several years now, and so, you know, this is our opportunity, and we have to we obviously have to take this opportunity in order to drive forward quality of care. Simon, you have your hand up.
Yeah, I can see a couple of questions, so I thought I'd start answering them, and then Richard and Jaffer can come in as well. So England or Wales, I think this is an England programme at the moment, but we would be happy to work with Wales, to be honest. If commissioners within Wales want to work with us, we're happy to have a similar process and learn from Wales as well, and similarly Scotland if they wanted to be involved. Obviously, and then timelines in terms of seeing changes, improvements identified by the transformation programme. This is not an endless programme. It is time constrained, so we would expect to see the changes, improvements delivered within the next 2 to 3 years, I would think, Richard, isn't it? And hopefully it's somewhat contingent on the revision of the long-term plan, because the long-term plan will be being revised, and we are sort of strongly suggesting that this is retained as a programme as we move forwards. But I would not like to see a transformation programme go on forever, because it will just drift. So we need to see change, we need to see it fast, and then essentially we need to move on to doing something else to be realistic. And then I think there was a really interesting question about funds associated with reducing inequalities for additional resources, and you know, where the issues are and how do you change within current resources. So the example is mental health. So it's a really big question. What I would say is that I think that increasingly, as clinicians, as providers, and from a regional and national perspective, we really need to focus on that inequality agenda, and that's what Jaffer's mentioned as part of the Core 20+5 programme. I don't think that program's perfect. I think that you don't look at a single aspect of healthcare and not realise those inequalities. And I think that another aspect of the CYP Transformation Programme, which is sort of, if you cut the epilepsy programme in inequalities in there, is that we absolutely have to have that focus on identifying the children that are most difficult to reach and most difficult to engage with, and ensure that they're there. If we see that there's the requirement for resource and we can develop the evidence base around it and where it needs to be from a national level, we will do our best to get funding into that to ensure. I think it's almost definitely cost effective to do that in the long run when you look at the impact of long-term conditions such as epilepsy on the health and wealth of our nation. So I think it's an easy one if we can have that data, and the data that Epilepsy12 is generating will undoubtedly help us in that. In terms of mental health, there is a significant amount of resource going into mental health and continues to go in. And I think, my soft intelligence is that on the ground, we're starting to see the impact of that, but it's still early days. But there is a program. In fact, the mental health program are over delivering in terms of their trajectory of increasing CYP mental health resources. But it won't be you may well be sitting in your hospital and not seeing that yet, but it's certainly on the way and it will come. And what we need to do within this program is to effectively integrate long-term conditions within children into those mental health services as we build them. So there's a number of ways in which we can get additional resource and reach the patients that we need to reach.
Thank you so much, Simon. Simon, Jaffer and Richard, thank you very much for giving us a glimpse of the future and outlining the sorts of NHS England structures that we can all contribute to, that we can all have input into, and that we can all use in order to leave a real change for our patients. So thank you so much, and we look forward to working very closely with you over the next few years.